Please start.
Okay. So, good evening, friends, colleagues, and respected seniors. I welcome you all to Quiz Junction episode 2. And today's topic is ovarian stimulation and fertility preservation. And this episode is being organized in collaboration with the SIG Fertility Preservation and Rajasthan chapter of IFS. To begin with, I privileged to invite our first speaker, Dr. Shweta ma'am. Ma'am needs no introduction. She is a director of Center of IVF and Human Reproduction at Sir Ganganam Hospital and a former General Secretary General of IFS. Currently, she is a first Vice President of IFS and a convener of SIG Fertility Preservation. She is an inspiring leader and a dedicated teacher. So we are truly privileged to have her with us today. Ma'am will speak on fertility preservation, selecting the right patient, choosing the right strategy. Ma'am, stage is
Thank you.
yours.
Yeah, thank you, Dr. Parul, for very kind introduction. I'll be missing Dr. Manjusha, but give my greetings to her. She's always been very enthusiastic when it comes to the quiz group. And along with you is Dr. Tejashri and Neha. So all the best for conducting all the quiz. And I'll just share my slide. Without much ado, so the task is that fertility preservation, whom to offer, when to offer, what practitioner should know. I have 20 minutes. This is a long presentation, so whenever my time is over, I'll stop. Fertility preservation can be defined as use of available technologies to help individuals who can retain their fertility or ability to procreate. Either we are talking about cancer patients or any benign disease like endometriosis, or related to any autoimmune disease, age-related fertility loss in transgender men. So there are many areas where we can explore fertility preservation. Now, oncofertility, a new discipline that merges oncology and reproductive medicine, which gives adolescent and young adult patients a chance to experience the joy of parenthood after the treatment is finished. And this term, oncofertility, was first named in 2015 by the American Society of Reproductive Medicine. The initiator and promoter of this discipline is Professor Theresa Woodruff. Now, what are the common indications for fertility preservation? Age, we know most of the patients who are coming to us are mostly voluntary, age related, and for social reasons. For whatever reason, they have their career goals, they want to go for further education, wanting to meet the right partner, they don't want fertility at the moment. Then, quite a significant chunk comes is now cancer. So we get a lot of referral for boys or for girls, especially when they're going through chemotherapy, radiation therapy, surgery for cancer, which can affect a person's fertility. But the problem is that, many a times we get a call when the chemotherapy has already been initiated. Like I got a call yesterday, and this patient has been receiving chemotherapy since April, and now she's waiting for her bone marrow transplant. Now, the problem is now this 25-year-old girl has come to me with an AMH of 0.04. So I cannot offer her. She's already exposed to lethal chemotherapeutic agents. The best time would have been when her disease was diagnosed and when the first chemotherapy was being initiated. That was the golden 2 weeks of time. If we would have received that, we could have done her oocyte freezing. Then autoimmune diseases, keep in mind lupus, rheumatoid arthritis, because they will have reduced ovarian reserves slowly. And then endometriosis, I know we all have become very aware, but it must be documented in your papers for the medical legal purpose that you have discussed endometriosis, severe endometriosis, and fertility preservation, so that you have sensitized that girl that there is a technology and she can preserve her oocytes, especially when you are seeing that her ovarian reserve has started to decline a bit. And that is the right time to discuss with her. So any female more than 2 years or up to 40 years can be offered ovarian reserve, oocyte cryopreservation or embryo cryopreservation. However, the ideal age will be less than 35 to 40 years. In males, it will be advanced or complete puberty, presence of sperms in semen or testicles. I don't think in India any pregnancy has been reported from testicular tissue cryopreservation and transplantation. I think in the world also. Patients diagnosed with cancer or hematological disease whose curative treatment has an intermediate to high gonadotoxic risk, that is more than 50 to 80%. Then patients diagnosed with cancer or hematological disease where a curative treatment has low to intermediate gonadotoxic risk, which is 20 to 50%, but they also have other conditions like additionally, they have a low ovarian reserve. They've gone through a previous ovarian surgery. In the boys, if there was a history of cryptorchidism, monoorchidism, previous testicular injury, etc. So patients who have not received previous gonadotoxic chemotherapy or have received only low doses, and patients receiving first line treatment with curative intent. So there are so many patients where an fertility preservation can be offered. Now, look at the amount of counseling they will need. They need to be aware. So, for patients to be aware, the doctors need to be aware. You should know the legal framework of the country. The medical records have to be absolutely in place. Like, I got a call for a patient where he had lymphoma and he had to go through a semen freezing. It sounded easy. I called him to the lab and he looked so unwell that day. His look was so toxic. And then his sister said that if he is not able to give the semen sample, can we do a testicular sperm aspiration today? And then I went through his medical records and I realized that his platelet count was only 20,000. So, of course, we could not have offered TISA on that day. If and unfortunately, he did give the semen sample, but it was only 1 million. So the next day, because he was admitted in the hospital, I called him in the morning again. But if we had to do TISA, we would have to give him apheresis, looked at his coagulation profile, and then done the testicular sperm aspiration. So it's very, very important to look into the medical reports before advising anything. Then there was a person who came to us and a testicular sperm aspiration had to be done. Same, he could not give semen by ejaculation and he had large masses because of lymphoma. So a pre-anesthesia checkup is mandatory because the anesthetist refused to give anesthesia in the IVF lab setting. So these are the challenges. So whenever you deal with an onco-fertility case, you have to be aware and known, and in conjunction with different teams, it has to be offered. Now, the standard forms: diagnosis, intended therapy, time interval, and what kind of fertility preservation approach you are going to inform has to be told. A proper informed consent. So, it is very important because in cases of an untimely death, what happens to the semen? You have to get it signed and kept with you for 10 years, and documentation of the stored material. Again, for 10 years, you will have to keep it. Now, treatments endangering the highest risk of POI, of course, is total body irradiation and chemo. Before bone marrow transplantation, pelvic irradiation, and chemotherapeutic agents like alkylating agents. So, sensitivity to gonadotoxic treatment again is age dependent. The relative risk of POI is around 10% in patients when they are less than 18 years, but it is around 30 to 40% in subjects who are less than 40 years. So factors which will increase the risk of gonadotoxicity: older age at diagnosis, lower pre-treatment AMH levels, type and dose of treatment, whether they have received chemo or radio, what is the anti-cancer treatment, risk of gonadotoxicity, other factors like smoking, BMI, are they carrying BRCA mutation, what is the diagnosis, which type of cancer, and targeted agents. So the diagnostic criteria for, as per the ESHRE guidelines, how will we diagnose POI? Either there is oligo or amenorrhea for at least 4 months, FSH levels more than 25 on 2 occasions, more than 4 weeks apart. The magnitude of this problem: 1 in 800 children are diagnosed with cancer today, and the long-term survival, which has increased in recent years, is around 70 to 80%. The fertility preservation is limited not only to patients with cancer, but also to all the other pathologies which are associated with elevated risk of an iatrogenic POI. So, Do you think it's on the higher side, fertility preservation? No. I think only, according to me, only 10% of girls who are counseled are actually going through fertility preservation when they have cancer. It is only social egg freezing which is so prevalent. It is inadequately addressed. Still, a lot of sensitization to the medical oncologist needs to be done, that when they have to refer and what is the right time to start fertility preservation. The biggest barrier is financial, then a noticeably longer time taken from diagnosis to oncofertility or consultation. So many times the family says, okay, let's get done with this disease first, and then we will think that, how to tackle the fertility part. So cancer treatment is a priority and treatment should not be delayed. So oncologists should have the decisive vote on whether to postpone the onset of cancer treatment because of fertility sparing procedures. So different fertility preservations are available to us. Ovarian tissue cryopreservation, I would say in India is still very, experimental, because we don't have any pregnancies reported from transplantation, though certain few centers are doing ovarian tissue cryopreservation, but we still don't know what is the survival once they are transplanted. Oocyte and embryo cryopreservation is a very robust technology. In oocyte cryopreservation, more than 95 survival is present in our center, and that is the time when you should plunge into oocyte cryopreservation, because if the survival is low, then your chance of giving pregnancy to the patient later on is very low. Hormonal suppression is more like an adjuvant therapy. Ovarian transposition, once or twice we have received patients where in the abdominal wall, the ovaries were transpositioned before pelvic irradiation. And pelvic fertility sparing surgeries, of course, is a good method, especially for borderline ovarian tumors. The most robust is embryo cryopreservation and oocyte cryopreservation. So, different cancers, if you're looking at prepubertal girls, we only have two options. Either we do a fertility sparing surgery or ovarian tissue cryopreservation. When we look at post-pubertal girls, adults, cervical cancer, either it is fertility sparing surgeries, whether it is conization, LEEP, tracheolectomy, ovarian transposition, uterine sparing surgeries. In the endometrial cancer, again, fertility sparing surgeries. This is one of the commonest, group which we see, especially in PCOS girls, if they have atypical hyperplasia or CNC2. Before hysterectomy, if we can give them in very, very early stages, we can give them medical treatment, and then we can kind of make pregnancy happen. In ovarian cancer, it's really difficult, but fertility sparing surgeries, especially for borderline tumors, can be undertaken. But very important is that once the family is complete, they should go for a complete surgery. Now, newly diagnosed breast cancer, give the counseling about gonadotoxic risk, discuss the desire for fertility. If you have more than 2 weeks, then the best is ovarian stimulation, followed by whether she wants an oocyte cryopreservation or embryo cryopreservation. If the availability is less than 2 weeks, then you'll have to do an ovarian tissue cryopreservation. That means that you will have to do a laparoscopy. I got a call for an 8-year-old girl. So after a lot of extensive counseling, but then the family was not really convinced, and they did not proceed for ovarian tissue cryopreservation. Now, desire to preserve ovarian function, if it is there, then you can give them a GnRH agonist chemotherapy. If the desire to preserve ovarian function is not there, then of course they are going to go for a complete surgery. So you have to counsel about adequate contraception during active treatment and follow up. Now, in lymphoma, cryopreservation of embryos or oocyte when cancer treatment is delayed. Again, ovarian tissue cryopreservation, in vitro maturation. I think in future we are going to see more of IVM. It's going to come back when this technique will be more robust, and possibly future with more AI, we will be able to do better when it comes to IVM. The protective effect of GnRH agonist is questionable and very controversial. But in prepubertal girl, of course, ovarian tissue cryopreservation is always an option, but the risk of ovarian failure after cancer treatment is quite high enough to justify the procedure. Now, 2 gyration of radiation is sufficient to cause 50% depletion of the non-growing growing follicle pool. However, other factors like what is the field of radiation, what is the fractionation schedule, what is the patient age at the time of treatment, and size of ovarian reserve, they play a huge role. So 18 gyration is needed to induce POI at the age of 12 years, whereas you need lesser 14 gray will have the same effect at around 28 years of age. So more the age, more is the damage. In chemotherapy, you know that the growing pool is affected. Now, I can share a very interesting case. A girl had come, doctor, I remember, and she was just on immunomodulatory drugs, not yet started on chemotherapy, and she was also waiting for bone marrow transplant. But unfortunately, when we did an OCR, all the oocytes were so abnormal that not a single could be frozen. So, the ideal time to freeze any oocyte is before you start any kind of treatment. Now, we know that alkylating agents like cyclophosphamide and procarbazine are the most toxic drugs to cause POI, especially which are used in childhood malignancies, in autoimmune diseases like SLE and rheumatoid arthritis, and prior to stem cell transplantation. The example which I just gave you, that this patient is going to go through a bone marrow transplantation and her ovarian reserve is totally knocked off after chemo. So other non-malignancy benign gynecological conditions can be ovarian diseases, endometriosis, adenomyosis, then any treatments which require pregnancy to be deferred, low ovarian reserve, risk of POI, family history of POI. Like I got a girl who was a carrier of Fragile X syndrome, and she had a younger sister because this girl had gone into totally into failure. So I got a Fragile X done for the sister also, to know that if she was a carrier of Fragile X mutation, then I would have offered the younger sister ovarian oocyte cryopreservation. And also, the younger sister wanted to become donor for the elder sister. And that is why doing a Fragile X mutation became important in the younger sister, because the elder one was a carrier. Any uterine malformations and conditions or surgeries affecting the fallopian tube. So I'm going through this slide. We just need to know that there can be, it sounds rosy, we can say that, okay, hematological disease, but there are risk of thrombotic events. In autoimmune disease also, there is a risk of thrombotic event. So we need to think whether the patients have to be on low molecular weight heparin for this particular disease. And then you will have to withdraw it just a day prior to the oocyte cryopreservation or 6 hours before. And then you will have to restart. If you're dealing with endometriosis, ovarian cyst, or borderline tumors, then there is an increased risk that she will respond very poorly, or there could be a risk of bleeding or infection, though that we don't encounter so commonly. But the genetic diseases where this counseling should be done is Fragile X, Turner's, galactosemia, BRCA carriers, POI in families, and Hurler syndrome. I personally haven't come across any Hurler syndrome in my clinical practice. So if we have to freeze, then oocytes are by vitrification, and ovarian tissue is mostly by slow freezing, and some centers are doing vitrification, but the more robust. So that is the problem, because the newer centers do not have a slow freezer at all. And you cannot go ahead with that freezing. And then if you have to go for fertility in future, then oocytes have to be thawed. They can be synchronized with the endometrial preparation and done with an embryo transfer. And if you are looking at cortical strip thawing, then either it is heterotrophic or orthotopic transplantation. And then we can either do an IVM, or we can transplant an artificial ovary. Now in Gangaram, in 1 year, if we did about 45 cases, then the cases done for malignancies or endometriosis were only 6. The youngest case where oocyte cryopreservation was done was of 16 years age. Now you don't have to inform the ART board. You can have an oncology board in your hospital, or you can make a small board and you can just present these kind of cases that we are going ahead and freezing the oocytes. Now you can freeze them for 10 years. After that, of course, you will have to take permission from the board to extend. So, of course, mature oocyte cryopreservation is the most robust technique in post-pubertal unmarried girls, and in married women, vitrification of embryos is the most robust method, stored in liquid nitrogen at minus 196. Now, coming to endometriosis, whom to offer? Bilateral endometrioma, recurrent endometrioma after surgery, endometriomas growing fast, and endometriomas at young age. So these are the four indications where you should be offering fertility preservation. Now, over oocyte cryopreservation, that is ovarian cortex. So it could either be done like in this young girl, I had to remove the whole. What I had proposed was to remove the whole ovary, make a small chunks, and then preserve them. And then it had to be, transplanted later, maybe in the ovarian fossa or little higher up in a window made beneath the peritoneum where we could collect the oocytes. This is what you would do, but you must always send the ovarian tissue biopsy for any malignancy. That is very, very important, especially if you're doing it for, unilateral ovarian malignancy. Like one girl, she had to go through again a doctor, a complete surgery, a radical surgery. We have done an whole ovarian tissue cryopreservation, but we are not very sure whether it's going to survive or not. But because she had a malignancy in her dermoid, that is why it is important that if we are freezing the other ovarian tissue, then we need to rule out that there are no malignancies. So I'll just run through it because we are at the last part of the presentation. So this is just the transplantation of the ovary. The first A picture shows that how chunks have been taken from the ovarian tissue and transplanted back into the ovarian tissue by tucking it with either sutures or staples, and a Surgicel has been placed. D, E, and F, they are showing that it has been placed in some other area and not the ovarian fossa. A window was made in the peritoneum. So this I have also not personally seen. When I had gone to Israel, I had seen that how they were transplanting it back into the ovarian tissue. So this is how the ovarian tissue transplantation would be seen, and the last picture shows a follicle growing. Now, of course, the merit and demerit, seeding tumor cells following ovarian tissue transplantation is the major concern. And you have to know that ovarian function generally will resume between 60 days to 240 days post transplant, and can last long. So ovarian tissue cryopreservation and transplantation and pregnancy can be considered in hormone sensitive tumors like endometrial cancer treated by fertility sparing strategy, or breast cancer after complete remission. But we have to really, really think that what do we, offer them. GnRH agonist. Now, this is just an additive therapy. Now, when we are left with nothing, then you can give them GnRH agonist few days before the chemotherapy, during the chemotherapy. The recent concept is that you can also give antagonist, but it has to be given on a daily basis. And maybe it might slightly help in, protecting the ovarian function, but it is very, very uncertain. This is ovarian transposition, where we are basically just fixing it in the lateral pelvic wall and high up in the ovary. So you can put a staple so that it can be located via the X-ray, or you can. The important point is that if you are transpositioning the ovary, make it in such a way that it doesn't go through a torsion. So a non-absorbable suture has to be placed before the irradiation, and you have to tell the radiotherapist that where exactly are the ovaries placed so that the pelvic irradiation can happen below it. So women with reduced ovarian reserve and at high risk of ovarian metastasis are inappropriate candidates for ovarian transposition. Challenges encountered: an impaired ovarian response to controlled stimulation in cancer patient, different stimulation protocols in terms of drugs, types, doses, and duration of stimulation. It needs a tertiary care. Now, this is important with expertise in ovarian, oocyte, sperm, testicular tissue cryopreservation, and also in high risk pregnancies. Age is the most important determining factor. This is my last two slides. So you assess the patient, The intervention, which we have said, whether ovarian biopsy, oophorectomy, ovarian stimulation, do an IBM, look, get oocytes, ovarian transposition, or consider GnRH agonist treatment. Now, if there is partner or donor sperm, the first will be unmarried girls, prepubertal, ovarian tissue cryopreservation, autotransplantation, in vivo growth of or artificial ovary, oocyte cryopreservation, and fertilization or embryo cryopreservation and replacement, which is, of course, the most robust method. Right now, a girl, she came to me before her marriage. I remember we had done an oocyte cryopreservation. She had CLL, she got treated, bone marrow transplanted, she got married. Now she made her embryos, and she is at the moment, I think, 28 weeks pregnant, and she's doing well. So, this is our lab. This is, we are just showing how we are doing the cryopreservation. So, to conclude, growing survival rates after experiencing cancer at a young age have been the major catalyst in recent decades for the development of new therapeutic strategies to address the long term consequences of oncological treatment. The risk of iatrogenic POI with subsequent infertility and a significant decline in quality of life is one of the main concerns of young female patients undergoing gonadotoxic therapy for malignant or benign conditions requiring these drugs. Counseling on fertility preservation options like oocyte freezing or OTC with oncologist and fertility expert is now considered one of the key elements in clinical management. Thank you so much for the patient hearing.
So thank you, ma'am, for such an informative and enriching and amazing presentation and sharing your valuable insights. Ma'am, I have one question. If we have to do, suppose, immediate gonadotoxic treatment and we don't have time for the conventional ovarian stimulation and patient opt for ovarian tissue cryopreservation. So what are the precautions we have to take before a reimplantation?
I think the patient has to be completely disease free.
Yes, ma'am.
That is the most important precaution you will do. You will have
Mm.
to get a clearance from the oncologist.
Mm-hmm. Yes, ma'am.
So your question was that if we only
We
have time
have
for ovarian
already,
tissue, yeah.
now we have to implant the ovarian
Yeah,
tissues.
so by the time she must have gone through a whole radical surgery and must
Mm-hmm.
have been given clearance, because
Mm-hmm.
see, oncology, we always talk about 5 year survival rate. I mean, if
Ma'am,
it crosses 5 years, it's great.
and if patient wants to 5 year survival, if patient wants to have within a two after 2 years, then we have to
Yes, we can. So after see, once they are done with their surgery and chemotherapy, we normally say 1 year, right? So the oncology team will be giving us the clearance. And depending on their clearance, we are going to say that, yes, you can go ahead with fertility.
okay, ma'am. Thank you, ma'am. Any other questions you have to ask Neha? Any question?
Ma'am, excellent presentation. I just wanted to ask that in patients who are suffering with these leukemias and lymphomas,
Hmm.
now these are the most challenging patients when we talk about fertility preservation, especially in standalone IVF centers. I think that's like a big take home message that they should be referred to places where you have a better facility and you have the tumor board and so any other precautions that you would say or you would
I
tell
would
us?
suggest that yes, in case of like lymphoma, what we came across, that she had huge mediastinal masses. So that cannot be dealt in, at standalone centers. They need a referral because the intubation could be difficult if required. Then, second, yes, tumor board, which you can also do it in your standalone units in conjunction maybe with how we have independent ethical, boards. Possibly that can be done, but most important is that your oocyte survival rate has to be excellent. And
Hmm.
that only your center will identify it. You should have done that, either how we started. I can tell you, we started freezing long time back oocytes from donors. We thought them, we saw their, survival rates. And that is how we plunged into fertility preservation full on with all kind of cases. So you have to have your benchmark on that. For oocyte cryopreservation, yes, that benchmark has to be achieved, and which is more than 95% survival rate.
Wonderful, ma'am. And we don't need any ethical clearance for fertility preservation for less
So,
than
you know,
18-year-olds,
yes, so
for
we
less than
don't need an
21-year-old?
ethical clearance because our law very clearly says that you can do oncofertility preservation.
Okay, ma'am.
Thank you,
Hi,
ma'am.
ma'am. Thank you, ma'am.
Thank
Thank
you
you
so
once
much.
again
Thank you so much.
Thank
for
you so
sharing
much,
your
ma'am.
experiences. Now we move on to next session. So I invite Dr. Neha to introduce our next speaker. Before that, I am to announce that our next episode on Quiz Junction will be on endometriosis and a tubal factor, and it will be on 28th of August. Okay, thank you. Thank you, ma'am.
Thank you, Dr. Parul. So I would like to introduce Dr. Urmila Sharma. She is the secretary for IFS Rajasthan chapter, and she will be talking about modern ovarian stimulation protocols, individualizing every IVF cycle. Dr. Urmila Sharma is the director for Ishwa IVF Jaipur, and she is the executive member of Rajasthan IFS and currently the secretary for Rajasthan IFS chapter. Over to you, ma'am. We welcome you and we look forward to great learning.
So, a very good evening, all of you. Am I audible?
Yes, you are audible, ma'am.
Yes, yes.
Okay, so my screen is visible to all.
Yes, it is visible.
Yes.
So, a very good evening, all of you. So, we'll be talking about the modern ovarian stimulation protocols. And because ovarian stimulation protocol is the most important part of any IVF cycle, it is the most complex one also. It is the part which is totally under our control, and it is the part where we decide the total number of oocytes which we will get at the end of the stimulation, and also we can prevent OHSS by properly selecting the ovarian stimulation protocol, and we can totally optimize the number of oocytes and embryos which we'll get at the end of stimulation. So it is a very important topic to understand. So the references is mainly latest ASHRAE guidelines. So if we talk about the latest ASHRAE guidelines, what actually has changed in the guidelines? So if we look at the guidelines, there are total 121 recommendations, out of which 46 are totally new recommendations. And one important thing is that the fertility preservation is now split into three areas. And the important points to note is that the poor responder is now termed as the low responder, because the poor word carries the prognosis, the label that the patient is a poor responder and she will have a poor chances of pregnancy. So the word has been changed to low responder. The fertility preservation has been divided into three areas. It is oncological fertility preservation, elective oocyte preservation, and the oocyte donation. And if we talk about the outcomes, now we talk in terms of the live birth rate per started cycle and the moderate to severe OHSS, and not just the oocyte number and clinical pregnancy rate. And for the first time, PPOS, duostim, and random stimulation protocols now carry formal recommendation in these guidelines. But how good is the evidence we are standing on? So most of the evidence is supported by it is of low quality, and not one recommendation is supported by high quality evidence. So if we talk about these recommendations, 42 are strong recommendations, 48 are conditional recommendations, and 29 are good practice points. Now, if we talk about what actually we are optimizing, so our target should not be to overstimulate the ovaries, over exhaust the ovaries by giving the maximum FSH dose and to get the maximum number of oocytes. Our main target should be to get a optimum number of oocyte at a physiological gonadotropin dose without risking the life of the patient and without increasing the risk of OHSS. If we talk about the in terms of ovarian response, we can categorize according to the low response, optimum response, and the high response. Low response is where we expect less than 4 oocytes, optimum is 4 to 18 oocytes, and high response is more than 18 oocytes. And if we look into the graph, as we see, as the number of oocytes increase above 18 to 20, there is hardly any significant rise in the live birth rate, but the risk of OHSS increases significantly. So it should be very clear that the doses of the gonadotropins selected should be optimum and not be very high enough as to increase the risk of OHS. Now, before starting the ovarian stimulation, our main important aim is to predict the ovarian response. And if we look into the guidelines, only two important parameters to assess the or to predict the response are the antral follicle count or AMH. We can use any one of these parameters, and there is no added advantage of combining both AMH or AFC. Do not use age, BMI, FSH, LH, estradiol, progesterone levels, or inhibin B to predict the ovarian response. But the response prediction is not the is should not be used for pregnancy labeling. So AMH and AFC will tell us about the number of oocyte which will get at the end of stimulation. But if we want to predict the chance of live birth, female age is the most important parameter, followed by BMI. So there is a strong recommendation that AFC, AMH, basal FSH, LH, E2, P4, and inhibin B are not recommended to predict the live pregnancy or the live birth rate. Now, when we start the ovarian stimulation, our main problem or the main key area is the how to prevent the premature LH surge, and for that we have various agents available for that. But if we talk in one line summary, the antagonist protocol is the default protocol which should be used for the general IVF population, and it should be mandatorily used in the predicted high responder. Everything else needs a stated reason. So in GnRH antagonist protocol, it has the highest graded recommendation in the guideline, and it is preferred over agonist protocols in the normal responders. Fixed antagonist protocol is preferred over the flexible one. Fresh transfer is permitted. If we talk about the long GnRH agonist protocol, fresh transfer is permitted, and it should be used only in selected cases only. If we talk about the progesterone primed cycles, the progesterone acts by inhibiting the LH surge centrally. We can use either medroxyprogesterone acetate 10 mg OD or dydrogesterone 20 mg or natural micronoise progesterone also. The most important thing is that the freeze all is mandatory in these cases. We cannot do fresh transfer. So it is optimum for while we are doing the donor cycles or fertility preservation cycles. In those cases, we can use progesterone primed stimulation. Now, if we talk about the fixed versus flexible antagonist protocol, the guidelines are in favor of the fixed antagonist start rather than the flexible one. And there has been a slightly increase in the ongoing pregnancy rate when we use the fixed protocol as compared to the flexible one. So you can start the antagonist either on day 5 or day 6, rather than starting at 12 to 14 mm size of the follicle. Now, one important protocol is the progesterone primed ovarian stimulation. So, and in this, as we have mentioned that oral progesterone is started with the starting of the gonadotropins. It will block the LH surge centrally. No antagonist injections are needed, and there is a down regulation of the pituitary by way of negative feedback. So we can use medroxyprogesterone, oral dydrogesterone, or micronized progesterone, and it is preferred protocol in oocyte donors. It is equally effective to the antagonist protocol. Can be used in the elective or oncological oocyte freezing, or where when we are doing the PGTA cycles and freeze all is the plan. Dual stimulation cycles, when we are planning to do, we can use the PPOS protocol. It will reduce the cost, it will reduce the number of injections, and also will reduce the clinic visits. So when we have started the stimulation, now the most important point is to select the right gonadotropin for stimulation, and there is a lot of confusion whether we should use the recombinant FSH or HMG, or whether we should add the LH or HMG. Is there any added advantage? The guidelines say that all are equally effective, whether you use the recombinant FSH or HMG or highly purified FSH, all are equal in terms of the outcome. There is no added advantage of adding the recombinant LH or HMG during the starting or the mid cycle. And adding of low dose HCG is also not recommended. Now, when we talk about the predicted high responder, normal responder, or the low responder, the starting dose is very, very important. If the patient is a high responder, we should always start with a lower dose of less than 150 IU. In normal responders, the standard dose is 150 to 225 IU, and in predicted low responder, 300 IU can be given, and there is no added advantage of increasing the doses beyond 300 international units. And there is no added advantage of adjusting the doses in the mid cycle. We should not increase or decrease the doses at day 5, day 6. You should start with the optimum dose, so that the same dose should be continued throughout the stimulations to get the optimum response and the optimum number of oocytes. If we talk about the various adjuvants, the guidelines do not support adding any adjuvants in the during the stimulation, and there is no rule of adding growth hormone, myoinositol, metformin, DHEA, aspirin. The only thing where letrozole or tamoxifen can be used is in the cases where there are hormone receptor, where there are tumors which are estrogen sensitive tumors. Where in these cases we can give letrozole or tamoxifen along with the stimulation. Otherwise, there is no role of adding any adjuvants in the stimulation. Now, another thing is about the monitoring of the stimulation cycles. So, according to the guidelines, only ultrasound monitoring of the ovarian stimulation cycle is sufficient, because it will tell us about the number of follicles, the oocyte, the follicle size, and these are the only two important things which helps us in deciding the day of trigger, the timing of trigger. So addition of the hormonal test like E2, P4, LH is not recommended either at the start or at the end of the cycles or in the mid cycle. The only exception is that you can do baseline day 2, day 3 estradiol levels when you see when there is a developing follicles, or if you want to rule out any functional cyst, then it will help in deciding the start date rather, and will not help in adjusting the dose of the gonadotropins. Baseline progesterone has no role in or the no added advantage in these stimulation cycles. Now, to decide the trigger, which trigger will act, and which trigger we should give in the particular cycle. So, before choosing the trigger, we should have an exit plan, whether we are planning to go for the fresh transfer or the frozen transfer. If the patient is a normal responder or a low responder and you are planning a fresh transfer, and then HCG trigger can be given. HCG in the dose of 5,000 or 10,000 urinary HCG or recombinant HCG, all are equal in terms of outcome. So HCG trigger should be given when we are planning a fresh transfer. When the patient is a hyper responder PCOS patient, or you are planning PGTA or freeze all in oocyte donors or in cancer patients, GnRH agonist trigger should be the choice, and it should be given as it is mandatory in the PCOS patient where there is a risk of OHSS. If we talk about dual trigger, it should be used only in selected patient, especially when there was a previous suboptimum response, low M2s were retrieved, and when in the previous cycle you gave the agonist and there were less number of M2 you retrieved. So in those cases, you can give the dual trigger. Agonist plus rescue HCG is given only when you have given the agonist trigger, and you have to do, you want to do fresh transfer, then you can give a rescue HCG 1500 units on the day of oocyte retrieval. Otherwise, it is better always to freeze the embryos in the agonist trigger cycles and do only frozen embryo transfer, because it causes early luteolysis, and the luteal phase support is not, you have to give very intense luteal phase support if you are giving the agonist trigger. So if we talk about the luteal phase support after luteal HCG trigger, vaginal progesterone is sufficient if you are going for the fresh transfer. After agonist trigger, as we have said, that you need intense luteal phase support with estrogen, progesterone, and rescue HCG. And most of the cases with the agonist trigger, you should plan for the freeze all. And if we talk about the OHSS prevention, the OHSS prevention should not be started at the end of the stimulation cycle where you see a lot of follicles. It should be started at the beginning of stimulation. The most important thing is to identify the patient who are at risk of OHSS by looking at the AMH AFC. So categorize the patient into the low, high, or normal responder. And if the patient is a hyper responder, identify the patient, use antagonist protocol, start at a low dose, give GnRH agonist trigger, freeze all embryos, and do a frozen embryo transfer. You can start cabergoline in the dose of 0.5 milligram daily for 8 days from the day of trigger. HCG should not be used if in case HCG should, if you are doing fresh transfer, then HCG should not be given. And the things which have a very low value in preventing OHSS are the ghosting. It only delays the cycle and it is poorly supported by evidence. IV albumin and Hestar are not recommended. Cycle cancellation should not be done. Rather, segmentation should be done by freezing all and doing a deferred embryo transfer. Metformin as a routine OHSS prophylaxis is not recommended in antagonist cycles. Now a word about the random start, luteal phase start, and the duostim. So random start means you are starting the stimulation randomly at any day of the cycle. It is a very good protocol where fresh transfer is not indicated. So it is equally recommended to a standard conventional stimulation protocol, especially in the oocyte donors. It can be done. And luteal start protocol is the protocol where we start the stimulation in the luteal phase of the cycle. Again, we have to freeze all the embryos. Fresh transfer is not done, and the oocyte competence is equivalent to the follicular phase start protocol. Dual stimulation is the protocol where we do a follicular stimulation and the luteal phase stimulation. So it saves time. The most important advantage is that in the patients where the age is more 40-41 year patient or the cancer patient who are having shortage of time, in those patient dual stimulation is helps in saving time and getting more number of oocytes in the same cycle. So the fertility preservation in the latest tertiary guidelines is divided into three arms. One is the oncological fertility preservation, one is elective oocyte freezing, and then the oocyte donation. So in onco patient and in patient with elective oocyte freezing, we can give start the random start protocol, and antagonist protocol should be started, or progesterone primed protocol can be given. And in cases of oncological patients where there are hormone sensitive tumors, letrozole and tamoxifen can be added in these cases. And in all these cases, GnRH agonist trigger should be the trigger of choice. So the principle that unifies all these three categories is that in every one of these population there is no fresh transfer. The single fact liberates the protocol. You may start on any day, and the trigger is always GnRH agonist trigger. So the 10 things that to unlearn is that more FSH will rescue a low responder. A dose above 300 international units is not recommended. It is a strong recommendation because it has a ceiling effect. It will only add to the cost and the side effects. The addition of adjuvants like growth hormone, DHA, testosterone, it is not recommended. The oral contraceptive pills, they are not recommended. They should be used only for the scheduling purpose. And flexible antagonist protocol, instead of flexible antagonist protocol, the fixed day 5 day 6 protocol is probably better. Freeze all will abolish only the early OHSS. Late OHSS from an implanting pregnancy remains possible even when we give the when we adopt the freeze all policy. Adjustment of the doses on day 6 should not be done. and you should start with an optimum dose so that the dose adjustment is prevented during the mid-cycle. Letrozole should be used only in cases of hormone sensitive tumors. It will not help in improving the outcome in standard protocols. And checking of hormonal levels E2, P4, LH during the cycle will not add any advantage. PCOS patients, especially if they are hyperresponders, freeze-all should be done. And AMH and AFC does not predict live birth rate. They predict only the oocyte number. Age is the most important predictor for the live birth rate. So assess the ovarian reserve, decide the trigger along according to the exit plan, whether you want to do fresh transfer or the frozen transfer. Fixed antagonist protocol should be used. Start 300 international units should be the highest dose in the even in the poor responders, and monitoring should be done with the USG alone. No added advantage of adding the hormonal test. So these are the key references. Individualization is not adding more, it is knowing what to leave out. Thank you so much.
Thank you, Dr. Urmila ma'am, for a wonderful presentation. It was very crisp, and you have clearly outlined all the ESHRE guidelines and all the strong recommendations when we talk about stimulation protocols. And I think our biggest take-home message is that we do not adjust the dose mid-cycle during our stimulations. We decide the dose when we are starting the protocol, and all these adjuncts are no longer recommended.
Yes. Yeah.
So, wonderful presentation, ma'am.
Thank you.
There is a question in the chat box. It says, can dual trigger be given if fresh transfer is planned?
As we talked that the if even if you are giving dual trigger has no added advantage in routine practice. If you are planning to do fresh transfer, better to give HCG trigger rather than the dual trigger. And if you are giving agonist trigger, better to freeze all and then do a frozen embryo transfer. So if you are planning fresh transfer, don't add an agonist. You just give HCG trigger and then plan fresh transfer.
Right. And as your presentation said, that monitoring the levels of LH is also not recommended according to ESHRE.
Yes, yes.
So only if the baseline LH was very low, then only we need to add HCG. Otherwise, agonist trigger works very well.
Yes, yes.
Thank you, ma'am. Thank you for a wonderful presentation.
Thank you.
Thank you. So I'll invite Dr. Tejshri now. Dr. Parul, you have any questions for?
No. We are running out of time, please.
All right. So I'll request Dr. Tejshri to kindly start the quiz.
Sure. So I think we have good amount of participants today and everybody is excited for the quiz.
Yeah.
I guess so. I can't see the participants, but I'm sure you all are very excited because 3 top winners are going to go to the IFS quiz straight away for Division 2026. So let us move on directly to the quiz. You have 20 seconds to answer each questions. We have 20 questions coming up. Very quickly, keep your fingers ready to give your options. So can we have the quiz on the screen, please? All right, so everybody is ready to start. Should we start the quiz? Yeah, let's start with it.
Dr. Tejashri, you can share the rules also how to enter.
So if I say the rules, please write the phone numbers. Do not write your names in this participant list, because when we are calculating the final outcome, it is only by your phone numbers, not by your name. So I see Yukti writing her name. Can you please put your phone number instead? Madhuri, can you please put your phone number and not your names, please?
Dr. Madhuri, hope you are able to hear us.
Dr. Tanu, Dr. Vijaya, you don't have to share the phone numbers in the chat box.
Only in the
Dr. Supriya.
participants we need. Don't write anything in the chat box. All the answers are to be marked on Kahoot, and everybody should just put their numbers in the participant list. We already have 19 people.
Madhuri, please share your phone number.
Has Yukti changed to phone number?
Yukti
I
has
can't.
changed. I think so. You
Yeah,
cannot
I think
see.
Dr. Madhuri has also changed. Dr. Anusha, you
Mhm.
can just enter your number on the Kahoot.
Dr. Vijaya is asking how to join quiz.
So you can scan the QR code
Just
and put the
just
pin.
download Kahoot app on your mobile, then join the Kahoot app quiz. This time.
This is a QR code, Dr.
I
Vijaya. You
think
have to just scan it, download it, and then join. And this is a PIN number 954213. You have to enter it.
Dr. Tejaswini, we can still see your name, so you'll have to enter your phone number. Dr. Tejaswini, if you can hear us, please change the entry to your phone number and not your name. Yeah, so Dr. Tanu, just scan the QR code on the screen and then enter the game pin that is displayed 954213.
You need to download Kahoot app or go on kahoot.it.
Once you open the app, it will ask for the PIN number. Am I right, Dr. Neha? I think that's how it is.
They just need to scan the QR and put the PIN. We have
Dr.
about
Tejaswini,
25.
we can still see your name. So you'll have to change to the phone number because otherwise we'll not be able to make out your answers. We have 26 participants, Dr. Parul.
Can we wait
Should
for
we
2
wait for
minutes?
2 minutes more? Okay.
Okay, 2 minutes. Dr. Anil. There's some Anil also.
Out of you doctors, somebody has registered by the name Anil. You will have to change to phone number.
Thirty participants only.
Dr. Tanu, were you able to join?
Nine three zero.
App spelling, Dr. Supriya is asking, it is Kahoot, Kahoot. It is
I
displayed.
think it also has an exclamation. So
It's displayed here, join at kahoot.it or with the Kahoot app.
Dr. Anil can change his phone number. It is still coming in his name.
Can we start in 1 more minute? I think. Dr. Tanu has also joined. Can we start now?
Sure, I think we should start. We have
Yes.
32 participants and
Yeah.
all the best, everyone. So here comes your first question. The best fertility preservation for a woman with a male partner and enough time for chemotherapy is oocyte cryopreservation, embryo cryopreservation, ovarian tissue cryopreservation, or IVM. Great. So we have 18 people who have answered correctly. Can we have the next question? Which cancer carries the highest risk of malignant cell reintroduction after ovarian tissue transplantation? Breast cancer, Hodgkin's lymphoma, acute leukemia, or cervical cancer carcinoma? Very nice. So here comes the next question. Which statement regarding ovarian tissue cryopreservation is true according to Eschrey? OTC remains experimental in adults. OTC is recommended only after failed ovarian stimulation. OTC is an established technique, but careful patient selection is essential. OTC should not be performed before puberty. Which is true? Perfect. We have great answers for this question. Next coming up, random start ovarian stimulation is based primarily on which physiological concept? Dominant follicle suppression, multiple follicular wave recruitment during menstrual cycle, increased LH secretion in luteal phase, or premature luteinization prevention? Perfect. So we have almost all correct answers for this question. Next one. Aromatase inhibitors are incorporated into ovarian stimulation in breast cancer primarily to improve oocyte maturity, reduce estradiol exposure without compromising oocyte yield, prevent OHSS, or increase implantation rates. Perfect, 25. Next question. Which of the following is not considered as a proven fertility preservation strategy according to Eschrey? Embryo cryopreservation, oocyte cryopreservation, ovarian tissue cryopreservation, GnRH agonist therapy alone? Great. Great going, participants. Well done. Which patient would benefit most from ovarian tissue cryopreservation rather than oocyte cryopreservation? a 35-year-old with early breast cancer and 3 weeks before chemotherapy, a 29-year-old requiring chemotherapy within 48 hours, a 32-year-old with elective fertility preservation, or a 38-year-old with diminished ovarian reserve undergoing IVF. Great. Perfect. So next question coming up. Which factor is strongest predictor of successful live birth following ovarian tissue transplantation? Duration of cryostorage, patient age at tissue harvesting, the type of cryoprotectant that is used, or orthotopic versus heterotopic transplantation. So seems like a easy quiz. Great going. Next question. According to Eshrey, ovarian transposition is recommended primarily in patients undergoing alkylating chemotherapy, whole body irradiation, pelvic radiotherapy, or hormonal therapy. I'm sure I'm going to get all correct answers for this question. Good. Next question, please. Which statement about testicular tissue cryopreservation is correct? It's a standard adult care, treats azoospermia, still experimental, or replaces sperm banking. Great going, participants. So halfway through and we have 10 more questions to come up. By 2020 Eshrey guideline, about how many live births followed ovarian tissue transplantation? Less than 50, 500, 130, or 1000? That seems to be a little confusing. All right, next question. Fertility preservation counseling should ideally include all except future pregnancy success rates, alternative family building options, a guaranteed fertility restoration, potential treatment delays that include the treatment. Okay, next question. Which chemotherapy agents are associated with highest risk of permanent ovarian insufficiency? This is the easiest. Platinum compounds, taxanes, alkylating agents, or anthracyclines. Next question, please. For prepubertal girls, which fertility preservation option is currently available? Mature oocyte cryopreservation, embryo cryopreservation, ovarian tissue cryopreservation, or random start ovarian stimulation? Okay, next question. According to Eshrey, fertility preservation counseling should ideally occur during chemotherapy, before referral to oncology, immediately after diagnosis, and before gonadotoxic treatment or completion of treatment. The principal advantage of vitrification over slow freezing for a mature oocyte is Low cost, reduced ice crystal formation with improved survival, reduced stimulation duration, improved embryo implantation independent of age. All correct answers. Okay. So question 17 is, which patient has the lowest expected benefit from ovarian tissue cryopreservation? 8-year-old with beta thalassemia, 22-year-old with lymphoma patient, a 41-year-old requiring chemotherapy, a 19-year-old sarcoma patient. The following factors predict individual risk of gonadotoxicity except older age at diagnosis, lower pre-treatment AMH levels, type and dose of gonadotropin, carrier of BRCA gene mutation. Okay. One to go. Endocrine function usually returns how long after ovarian tissue transplantation? 1 week, 2 to 4 weeks, 1 to 2 months, or 3 to 6 months. So here's the last question coming up. Which best reflects ESHRE approach to fertility preservation? Only IVF centers should offer. Counseling is optional, or all at-risk patients need timely multidisciplinary counseling. Only if infertility risk exceeds 50% should we do a fertility preservation. I'm expecting all correct answers. Perfect. All right. So can we have the results right away? I'm sure we don't have a tie here, right? So congratulations to all the 3 winners. Thank you for participating, everyone.
All 3 winners, kindly share your mail ID and your phone number in the chat box. All winners, please share your mail ID and phone number in the chat box. शेयर नहीं कर रहे हैं.
We have the numbers, so can we personally just send them a message and ask for the email ID?
फोटो लिए हैं.
I have taken the picture for.
अच्छा, okay.
Yeah.
हाँ.
Yeah, we have a picture of this, so we can personally message them to ask their email IDs if.
Okay, fine. Tripti Aneja.
What's the phone number for Tripti Aneja?
Position 2. Tripti, kindly share your phone number also. Dr. Neha, can you take the
Yeah.
Yeah, I have
Uh-huh.
taken the picture,
Okay.
Dr. Neha. I've taken all three pictures. All emails
So
have also
thank you,
received.
Dr. Tejashree. It was one of the difficult topic to make the MCQs.
Absolutely.
You conducted the quiz so well. So I want to thanks all participants for your enthusiastic participation. And most important announcement, our next Quiz Junction episode will held on 28th August, and topic will be endometriosis and tubal factor. I also want to thank our speakers, Dr. Shweta Mittal ma'am and Dr. Urmila, for giving such an informative presentation.
Thank you.
And our mentor, Dr. Manjusha, she's not here. We are missing her a lot. And Dr. Neha and Dr. Tejashri in organizing this session well. And thank you once again. And also one important thing, we want to thank our sponsor, UNS, for supporting us. Thank you.
Thank you,
Thank you.
Dr.
Thank you,
Marugetti.
everyone, for joining.
Thank
Thank
you.
you, Dr. Urmila. Thank you.
Good evening.
Thank you.